Every time you pick up a scalpel to perform what clients usually refer to as just a simple fix, you're doing so much more than just preventing a litter of puppies or kittens.
Oh,
I
absolutely.
mean, the moment you sever an ovarian ligament or, ligate of vastus accumbens, you are fundamentally and permanently altering that patient's skeletal growth, their metabolic burn rate, their lifelong disease risk, and sometimes even the color of their hair.
Right. It's basically the biological equivalent of rewriting a patient's entire internal operating system.
Yeah.
But, because we do it so frequently, the profound physiological cascade triggered by neutering and castration, it often just gets overshadowed by the sheer volume of these procedures in daily practice.
Totally. And that is exactly our mission for this deep dive today.
Yeah.
Because you, the listener, you are a veterinary student, and very soon these procedures are going to be your absolute bread and butter.
Oh, for sure.
We have this really comprehensive clinical guide sitting right in front of us, and it covers surgical indications, complications, anesthetic protocols, and of course the massive metabolic shifts associated with all of this.
Which is a lot of ground to cover.
It is. So we are taking the textbook and we're turning it into the exact clinical pearls you need for your pre-rounds.
Because when an owner looks at you in the exam room and asks why or when,
Yeah.
handing them some generic pamphlet just won't cut it, you really need to understand the underlying mechanisms.
Exactly. So before we step into the OR, we really have to lock down the lexicon, right?
Yeah, precision in our terminology really dictates the clinical expectations that we set for the owner.
Mm.
Because we use neuter as a blanket term, but the specific anatomy we remove completely changes the long-term outcome.
Right. So clinically, the debate often centers on whether to perform a full ovariohysterectomy, an OHE, or just an ovariectomy, an OVE. Since both remove the ovaries and, the main hormonal driver, the long-term outcomes are effectively identical. But leaving the uterus behind in an OVE, it often makes owners really nervous about pyometry.
Which, that's a valid concern for a layperson. But as a clinician, you have to explain that without the ovaries producing progesterone to stimulate that uterine lining, the risk of pyometra in an OVE patient is virtually non-existent.
Wait, really? It's that low?
Yeah, it's biologically just not going to happen.
Yeah.
The real complication arises with the ovary-sparing surgery, or the OSS,
Okay, right.
because that is simply a hysterectomy. So the uterus is gone, preventing pregnancy and pyometra, but the ovaries remain. So the hormonal cycle and all the behaviors associated with it, they just continue completely unabated.
Oh, wow. And for males, a vasectomy leaves the hormones intact by just transecting the vas deferens.
Exactly.
Whereas castration, which technically that applies to removing male or female sex organs, though we usually just use it interchangeably with orchiectomy that removes the testicles and the testosterone entirely.
And that hormonal distinction is like the perfect pivot to the behavioral realities. Because this is a conversation you will have every single day, disculling the myth that castration is some cure-all for a poorly trained dog.
Yes. Oh my gosh. Owners treat it like a magic wand.
They really do.
They bring in a dog that resource guards or jumps on guests or just pulls constantly on the leash, and they expect an orchiectomy to just fix it.
Which absolutely won't.
No. So we have to break it to them that surgery only targets hormone-driven behaviors. Those inherited or, learned bad habits, they are staying put unless they actually put in the training hours.
Right. Neutering modifies very specific actions. So in queens, you are eliminating that persistent calling behavior.
Which is so intense.
It is. And if a queen cycles continuously without mating, she can actually suffer a pretty severe loss of bodily condition just from the sheer metabolic toll of that calling behavior. Not to mention, the practical issue of attracting tomcats.
Oh, for sure.
And in male cats and dogs, removing testosterone reduces the biological imperative to roam, which subsequently cuts down on territorial marking and fight-associated diseases. But general behavior. A hyperactive Labrador will still be a completely hyperactive Labrador post-castration.
Yeah, unfortunately for the owners. But the medical prophylaxis, the actual disease prevention, that is where the data is just undeniable.
Oh, definitely.
Spaying prevents pyometra and false pregnancies, and we know it significantly reduces the incidence of mammary tumors. But there is a massive caveat there regarding the timing, right?
Yes, a huge one.
Because to get that dramatic statistical reduction in mammary neoplasia risk, the spay has to be performed before the female's second season.
Right. And looking at male prophylaxis, castration completely eliminates the risk of testicular neoplasia because, well, the target tissue is gone.
Makes sense.
And it also severely reduces prostatic disease. But the absolute clinical rule here involves cryptorchidism.
Oh, the retained testicles.
Exactly. If you have a patient with retained, undescended testicles, their removal is mandatory. The higher temperature within the abdomen or the inguinal canal makes those retained testicles highly, highly prone to malignant transformation.
Wow, okay. And we also use neutering as an adjunctive treatment, don't we? Because sex hormones can exacerbate or maintain other diseases.
They do. So removing those hormones is actually a critical step in managing perineal hernias and circumanal adenomas in males.
Interesting.
And in bitches, progesterone creates severe insulin resistance. So it's nearly impossible to stabilize a diabetic patient without spaying her first.
Right. So if we are relying on these surgeries to alter behavior, prevent specific cancers, or even manage diabetes, the exact moment we intervene biologically becomes the most critical decision we make.
It dictates absolutely everything.
Because if you cut too early, we risk one set of complications, and if we cut too late, we risk another.
It's a total tightrope walk.
Hmm.
And the protocols are distinctly split by species, which is something you really have to remember for rounds.
Okay, let's break that down.
The clinical consensus for cats, both male and female, is to operate before puberty, typically around 16 weeks of age, because we want to prevent the onset of the roaming and calling behaviors entirely.
But waiting 18 months for dogs, as the guide recommends, that seems kind of counterintuitive if we want to prevent behavioral issues early, doesn't it? Like, is this a trade-off between behavioral control and orthopedic health? Are we waiting for the growth plates to close?
That is exactly the trade-off. Sex hormones signal the closure of the epiphyseal growth plates in the long bones.
Ah!
So if you remove those hormones at 16 weeks in a large breed dog, the bones literally continue to grow longer than they genetically should.
Wait, seriously?
Yeah, and this alters the biomechanics of their joints, which potentially increases the risk of cranial cruciate ligament tears and other really severe orthopedic diseases. So we delayed to 12 to 18 months just to allow for skeletal maturity.
Wow. But for female dogs, delaying the spay means navigating their estrus cycle. And there are literal danger zones here. Like, what happens if we spay during diestrus?
Okay, so diestrus is the period right after heat when progesterone is really high. If you abruptly remove the ovaries during this phase, the sudden, precipitous drop in progesterone actually mimics the hormonal drop that occurs right before parturition.
Oh, no.
Yeah, the body literally thinks it just gave birth. So it triggers a severe pseudopregnancy, complete with lactation and behavioral nesting.
That is wild. And what if they are in active heat? What if they're in estrus?
Operating during estrus drastically increases your surgical risk. Estrogen heavily influences the coagulation cascade and local blood flow.
Right.
So the entire genital tract becomes engorged, it's incredibly vascular, and the tissues become extremely friable, meaning they tear really easily under the tension of a spay hook or a ligature.
So, spaying during estrus is kind of like trying to do delicate plumbing work while the main water pressure is turned up to the maximum. Like everything is swollen, vascular, and ready to bleed profusely at the slightest nick.
That is a very accurate analogy. It takes what should be a routine procedure and introduces a really high risk of intraoperative hemorrhage.
Yikes.
So the sweet spot, the safest plumbing environment, to use your terms, is an estrus. Operating 3 months after their last season ensures the tissues are quiet, the vessels are normal size, and the hormones have leveled out.
Okay, that makes perfect sense. But even with perfect timing, the procedure carries the inherent complication of irreversibility.
Always.
And if the surgical technique isn't absolutely flawless, the biological cascade kind of backfires, right? Because leaving an ovarian remnant means the tissue continues producing estrogen and the dog goes right back into heat.
Exactly. And leaving a uterine stump creates a reservoir that's totally susceptible to stump pyometra.
Right.
But beyond surgical error, there are consequences directly tied to the hormone loss itself, like sphincter mechanism incompetence. Urinary incontinence is a major one. It is actually 8 times more common in spayed bitches than in intact ones.
8 times. Wow, and this ties directly back to our timeline debate, right? Because the risk of urinary incontinence is significantly higher if the bitch is spayed before her first season.
Yes, exactly.
So that completely recontextualizes the 12 to 18-month waiting period. Like, we aren't just protecting their growth plates, we're actually protecting their urethral tone.
You are always balancing systemic risks. Another risk of early spaying is the persistence of infantile genitalia.
Which means what exactly?
Basically, the vulva remains recessed. And this anatomical dead space traps moisture and bacteria, leading to chronic vulval fold dermatitis.
Oh, that sounds awful.
It is. And if that dog later develops obesity or the urinary incontinence we literally just mentioned, the dermatitis becomes this severe, continuous cycle of infection.
Okay, so there are distinct risks for males too, though, because the guide notes that male dogs with inherently placid temperaments can sometimes experience a really severe drop in drive post-castration.
Yeah, they become extremely lethargic once that baseline testosterone is just gone.
And then there is the fascinating phenomenon regarding coat color. This blew my mind.
Oh, the coat anomaly.
Yes, if you are operating on a color point breed, like a Siamese or a Burman cat, you absolutely have to warn the owner about the clippers.
You do. Because in those specific genetics, the hair that regrows over the shaved surgical site will often come back significantly darker than the surrounding coat.
That is so bizarre.
It really is. And some dogs also retain a juvenile texture and color to their fur permanently. It's just this really striking visual reminder that sex hormones regulate far more than just the reproductive tract.
Right. So, with risks ranging from lifelong incontinence and altered bone growth to, lethargy and coat changes, what is the middle ground? Like when an owner sits in the exam room and they're hesitant to make an irreversible surgical choice, we can offer a chemical alternative.
We can, yeah. Through chemical control using GnRH agonist implants, primarily deslorelin.
Okay, so for male dogs and cats, how does this deslorelin implant actually bridge the gap?
Well, it creates a reversible suppression of testosterone by continuously agonizing the GnRH receptors that eventually downregulates them,
Okay.
which halts the production of testosterone and induces infertility. It takes about 6 weeks to reach full efficacy, and that suppression lasts anywhere from 6 to 12 months.
Okay, so could we use this as a diagnostic test drive?
What do you mean?
Like, say an owner wants to castrate purely to stop a behavioral issue, but we aren't sure if the behavior is actually hormonally driven or just a learned bad habit.
Oh, I see.
Right. So we place the implant.
Okay.
If the behavior resolves over the next few months, we know surgical castration is the right call. If the dog is still a total menace, we know surgery wouldn't have fixed it anyway, and the owner is saved from an irreversible procedure.
That is actually one of its most valuable clinical applications. It actively prevents unnecessary surgery.
That is so cool.
It is. However, the application for female dogs is much more restrictive. While it's licensed for prepubertal dogs to delay heat, the clinical guide explicitly advises against using these implants in adult cycling females.
Oh, really? Why is that?
The hormonal feedback loop in an adult female is just too complex, and introducing the agonist can actually induce a fertile estrus before it ever suppresses the cycle.
Oh, wow. Talk about an unintended consequence. Okay, all right, so let's assume the decision is made. The timing is optimal, the client is fully informed, and we are proceeding with surgery. The theoretical debate ends, and strict protocols begin.
This is where the rubber meets the road.
Exactly. Let's walk our vet student listener through the operating suite recipe, starting with pre-op prep.
All right, first up is fasting. The standard is withholding food for 12 to 18 hours for adult patients.
Right.
But for pediatric patients, you adjust that to just 4 to 6 hours. Pediatric patients have really minimal hepatic glycogen reserves. So if you fast them for 18 hours, you run a very high risk of profound hypoglycemia under anesthesia.
That is a crucial distinction. And what about bladder management?
You must express the urinary bladder immediately before induction. Operating around a distended bladder restricts your surgical field and drastically increases the risk of accidental iatrogenic trauma.
Like nipping the bladder wall with a scalpel or suture?
Exactly, you want it empty. Additionally, if your patient is over 5 to 7 years old, baseline preoperative blood work is completely mandatory. You need electrolytes, liver enzymes, BUN, and creatinine.
Because we have to confirm renal and hepatic clearance before introducing any anesthetic agents.
You got it.
Which brings us to the pre-medication protocol.
Right, so the standard is a multimodal approach.
Yeah.
You want an opioid for analgesia combined with an alpha-2 agonist for sedation.
Okay.
The guide specifies methadone at 0.3 to 0.6 milligilokilograms intramuscularly, combined with medetomidine at 10 to 20 micrograms per kg/IM.
Got it. And the induction agents are where the protocol strictly splits by species, right?
Yes, very strictly.
So dogs get propofol intravenously at 2 to 4 mg/kg, and cats get ketamine the fourth at 5 mg/kg. And this isn't arbitrary.
Not at all.
Propofol provides the smooth, rapid induction suitable for the canine cardiovascular profile, whereas ketamine aligns way better with feline physiological responses, maintaining their cardiac output more reliably during induction, provided the dosing is exact, of course.
Exactly.
Yeah.
And when you're implementing local anesthetic blocks like an intracasticilar block or a splash block in the ovarian pedicle, We use lidocaine.
Right.
But you absolutely must respect the absolute toxic limit of 4 millikilogram.
Because if you exceed that, particularly in small patients, it quickly crosses the blood-brain barrier and triggers systemic toxicity and seizures.
Yes, it happens very fast.
And the analgesia protocol reveals another massive species divide, specifically regarding meloxicam.
Yeah, the NSAID divide basically comes down to renal clearance and hepatic metabolism. Dogs receive an initial meloxicam dose of 0.2 milligrams subcutaneously or orally, followed by a maintenance dose of 0.1 milligrams every 24 hours.
Because they process the drug pretty efficiently.
Right. But cats receive a higher initial dose, 0.3 milligrams subcutaneously. But it is explicitly advised not to follow up with oral meloxicam 24 hours later.
Wow, okay. And that's because feline renal systems are incredibly sensitive to NSAIDs, right?
Exactly.
So the risk of tipping them into acute kidney injury with continuous dosing totally outweighs the analgesic benefit when we have other pain management options anyway.
Precisely. You
Right.
really have to be careful with cats and NSAIDs.
So, let's talk about antibiotics. Because as a student, the instinct is often to blanket the patient in antibiotics just in case.
Right.
We are cutting into the abdomen. We obviously want to prevent infection. But the clinical sources explicitly state no perioperative antibiotics for elective OVE, OHE, or castrations. Is this purely an antimicrobial stewardship issue, or is it about trusting our technique?
Well, it is the absolute cornerstone of antimicrobial stewardship. Elective spays and neuters are categorized as clean surgeries.
Okay.
There is no existing infection, and you are not entering the respiratory, gastrointestinal, or urinary tracts where bacteria naturally reside.
Right, that makes sense.
So if your surgical suite is properly maintained, your instruments are effectively autoclaved, and your sterile scrubbing and draping techniques are flawless, the risk of introducing bacteria is negligible. Prescribing antibiotics, just in case, breeds resistant superbugs and annihilates the patient's gut microbiome for zero clinical gain. Trust your sterile technique.
Trust your sterile technique. I love that. Okay, so the surgery is a success. The patient is awake. The sterile field held up. But the internal engine of that patient has fundamentally changed. The remainder of their life is entirely about managing this newly altered metabolism.
This is the universal postoperative reality.
Yeah.
Neutered animals are significantly more susceptible to obesity.
For sure.
For breeds already genetically predisposed, like your Labradors, Golden Retrievers, Spaniels, Collies, you are fighting a battle on two fronts.
Let's unpack the mechanics of that weight gain, because the hormone drop affects the metabolic engine differently depending on the sex, doesn't it?
It does.
So for male dogs, castrating removes testosterone. Without testosterone, their baseline metabolic rate drops. So they burn fewer calories just existing. But concurrently, their appetite either stays the same or actually ramps up.
Yeah. And if the owner continues to feed the exact same volume of food post-surgery, the dog is taking in fuel for an engine that just got downsized. Weight gain is mathematically inevitable.
Right. And for spayed female dogs, the mechanism hinges on estrogen. Estrogen naturally suppresses appetite and upregulates metabolism.
Exactly.
When you remove the ovaries, estrogen bottoms out, the metabolism slows down, and the satiety signals diminish. They literally feel hungrier while burning less.
And the feline side of this metabolic shift is where owners make the most dangerous mistakes, specifically with ad-lib feeding.
Oh yeah, leaving a bowl of dry food out all day for a neutered cat is just a recipe for disaster.
It is incredibly dangerous because a castrated male cat loses the testosterone that drives his desire to roam and patrol territory. So his physical activity plummets, reducing his energy requirements drastically. Simultaneously, without the distraction of roaming, his focus shifts massively toward food.
And for spayed female cats, the loss of estrogen triggers that same dual threat. Their appetite surges while their baseline caloric burn just drops.
And if owners give in to that heightened food focus and allow ad-lib access, the rapid weight gain triggers severe secondary pathologies.
Like what?
Well, neutered cats fed ad-lib face a sharply heightened risk of developing diabetes mellitus and hepatic lipidosis of fatty liver disease.
Wow.
We are talking about complex, expensive, and frequently fatal conditions born entirely out of postoperative dietary mismanagement.
So we're essentially taking their biological engine, giving it a smaller gas tank, but hardwiring the dashboard to constantly flash the feed me light.
That is exactly what we're doing.
It requires a massive shift in client communication. You aren't just sending a patient home with stitches. You are sending them home with a new metabolic reality that requires strict portion control and active weighing.
And a successful surgery is only half the job. The clinician's true test is ensuring the owner actually understands how to manage that biological aftermath.
And that brings us to the core takeaway for you, our listener. A routine spay or neuter is really a misnomer. Mastering these procedures means mastering endocrinology, pharmacology, surgical timing, and client education.
It requires a holistic understanding of how removing a single organ reshapes the entire organism.
Absolutely. So as we wrap up this deep dive, I want to leave you with a provocative thought to sort of mull over during your next set of rounds.
Okay, let's hear it.
We have established that removing sex hormones instantly alters a patient's metabolic burn rate, it changes their bone growth, shifts their behavioral drives, and can even alter their hair color. We know the immediate cascade,
Right.
but what are the subtle, long-term systemic effects of living completely without sex hormones for 10 or 15 years? Like, what are the shifts in a dog or cat's neurochemistry, their cognitive aging process, or their immune function that veterinary medicine hasn't even begun to fully measure yet?
That is a great question. It really forces us to continually reevaluate the true lifelong footprint of our most common interventions.
It really does. So the next time you look at that surgical schedule, remember, you aren't just going through the motions. You are the architect of that patient's lifelong biological cascade. Good luck on your rounds, and thank you for taking this deep dive with us.